Hello, everyone. My name is Olivia Jacquemart. I am a QA and trainer with ViaQuest Psychiatric and Behavioral Solutions. And today, we are going to be going through mental health documentation and medical necessity. Before we can go through the PowerPoint, we have to know what we are trying to learn. So we want to define clinical documentation and medical necessity, identify the regulatory requirements as they relate to clinical documentation, describe the necessary components of mental health assessments, evaluate the role of documentation in treatment planning, describe how to properly create progress notes and the importance of justifying medical necessity, and lastly, identify the process and necessary parts of discharge summaries. We need to make sure that we focus on our documentation as documentation is the primary focus of clinical chart audits. These are heavily scrutinized by regulatory bodies. Documentation that does not support medical necessity could result in a recoupment of funds and, in extreme cases, a loss of clinical licensure for the agency. All practicing behavioral health providers are required to meet regulatory standards of practice and must have a working knowledge of medical necessity. When auditing charts, the reviewer should be able to have a clear understanding of the following: what occurred during each individual session, what was done, why, how did the client react, then a general idea of the treatment plan or purpose of treatment. We should know the client's state of mind during the session with the provider. What we mean by that is that mental status exam or MSE. And lastly, the plan or next course of action in treatment. There should always be some sort of follow-up between sessions. Someone will be doing something. Ideally, clinical notes should provide a clear account of the time that is spent with the client. But why is documentation so important? So documentation is critical for a few reasons, including it being the cornerstone in the regulatory process. It serves as evidence of treatment service history. It is part of the client's legal medical record. With documentation, there is support for the whole treatment process, as well as justifies the efficacy of the treatment being provided. There is a requirement for meeting regulatory standards of practice, and the content of medical records are essential for patient care, accreditation, and reimbursement purposes. All behavioral health providers are required to meet these standards in the state of Ohio. Two primary goals of clinical documentation. So it serves as a tool that guides the clinical process and aids in measuring outcomes. So that's like the PHQ-9, the GAD-7, remember we call those our outcome measures. And it provides the content required for the client's clinical chart, aka that legal medical record, which is PHI or Protected Health Information. Standards and regulations are administered and monitored through insurance companies, whose regulations are directly related to higher levels of governance. This includes federal, state, and local governments and accreditation agencies. The main accreditation agencies we follow the guidelines of are the National Committee on Quality Assurance, or NCQA, the Joint Commission, or TJC, and the Commission on Accreditation of Rehabilitation Facilities, otherwise known as CARF. We have made a note that our documentation and session need to be medically necessary, but what is medical necessity? So according to the O8C, or the Ohio Administrative Code, medical necessity is defined as healthcare services that a healthcare provider, exercising prudent clinical judgment, would provide a patient for the purposes of evaluating, diagnosing, or treating an illness, disease, or its symptoms, and that are 1, in accordance with the generally accepted standards of medical practice, 2, clinically appropriate in terms of type, frequency, extent, site, and duration, and considered effective for the patient's illness, injury, or disease. And lastly, not primarily for the convenience of the patient or healthcare provider, physician, or any other healthcare provider, and not more costly than an alternative service or sequence of services at least as likely to produce equivalent therapeutic or diagnostic results as to the diagnosis or treatment of that patient's illness, injury, or disease. Really, what that last bullet point is trying to tell you, don't just see a patient because you want to see them or they just want to see you, but it's not really necessary. We want to make sure that we are providing this service because it is necessary for them to see you or you need to see them. Generally accepted standards of medical practice means standards that are based on credible scientific evidence published in peer-reviewed medical literature, generally recognized by the relevant medical community. So physician and healthcare provider specialty society recommendations. The views of physicians and healthcare providers practicing in relevant clinical areas and other factors. So how do we know we are able to get medical necessity? So we have a checklist. So there is a checklist that we need to make sure we are going through, such as the client must demonstrate symptoms consistent with the primary DSM-5 diagnosis of a psychiatric disorder and or substance use problem, be motivated and engaged, agree to comply with the treatment plan, and have a system in place to ensure follow through with the plan. They need to actually participate in their own service. And then we want to maintain a current level of functioning through outpatient treatment. So VPBS provides that outpatient level of care. And we want to make sure that we are able to provide them with that same level of functioning. And then the client must have an impaired level of functioning in areas such as self-care, work, family, living, and social relations, and outpatient care will help increase that level of functioning. The client will experience increased intensity or duration of symptoms with a diagnosis of mental illness and or substance use without treatment. So without our help or without our support, they would get worse in their diagnosis and symptoms. Clinicians should write chart notes that they would feel comfortable sharing with the client. So some providers include clients when writing notes by practicing collaborative documentation during sessions. This literally means you are writing your documentation in collaboration with the client you are in session with. This is also called concurrent documentation. The documentation and session are happening concurrently. Conversely, information referring to a risk of any kind must be well documented. The key is to state facts and to write in an objective and neutral manner, making sure that we are professional in the language we are using. And a few guidelines to keep in mind: only keep one set of notes, avoid subjective statements and opinions, and use the client's own words whenever possible. That is a great way to make sure that we are making our documentation individualized. And an easy way to make sure that we are showing medical necessity is by this, the golden thread. So the easiest way to explain the golden thread is that there is the tying of all relevant information throughout all documentation. So each element in the therapeutic process, from intake to discharge, must be clearly documented so that the connection between all aspects of the clinical workflow logically from one record to the other. If the golden thread is maintained, documentation will support each decision, intervention, and note, contributing to just a full, complete record of client care that reflects your work with integrity. It's also respectful of the client confidentiality and will pass an audit. This will get reimbursed then by insurance companies. So all of this is why it is critical to make sure that we are reading the psych eval or the assessment prior to starting our services. We are making sure that we're putting all relevant information throughout all documentation. A few other factors to keep in mind when completing your documentation: only keep that one set of notes. This just makes it easy for yourself when writing. You're not trying to look for a bunch of different things, trying to go through all types of different papers to write one option. And then avoid subjective statements or opinions. We need to make sure that we are being objective and providing evidence for our notations. And then remove judgment from language in documents. That is unprofessional, and we as clinicians need to make sure that we are writing notes professionally. And then lastly, avoid labeling. Especially if you are unable to do any diagnosing, you should not label your clients in any way. So those subjective statements or opinions, what we need is what was incorrect. Client was angry. Well, how do you know that information? So we know because the client reported she was angry, or the client appeared angry as evidenced by. So not only do we have evidence for this reason, we can back it up, right? So she reported, or this is what we can see clinically. It's not just a subjective opinion. And then labeling. So what is incorrect there? Client is lazy and will not help himself. What's correct? This clinician has observed that the client is struggling with the lack of motivation. That lack of motivation, we can see there, secondary to his diagnosis of major depressive disorder. So he has been diagnosed by the correct professional. And so we do not want to say, oh, the client's just lazy. Instead, this clinician has observed a lack of motivation due to the diagnosis. And then next, we will go through the assessment and or evaluations that are done on clients prior to beginning services. The purpose of the assessment includes that it gives global perspective of presenting problems. There's a basis for diagnostic formulation. It identifies early treatment needs and aids in the ITP development, ITP, ISP, care plan, treatment plan, service plan, whatever you would like to call it. And it assesses client history or the current level of risk to self, others, or property. Just also a big one here is that it can aid in rapport building if the assessor is going to be working with that individual further. And then we will begin into the actual presenting problem and diagnosis. The initial symptoms of a mental health issue for which a person seeks help, that is absolutely going to be that referral problem, that presenting problem at the time of treatment. So we have an example here, how to operationalize this presenting problem. First, you have the diagnosis. The diagnosis is major depressive disorder, plus symptoms or the criteria that are allowing us to make that diagnosis. So it could be disordered sleep, somatic complaints, irritability, trouble focusing. And then you want to rate the level of impact, the frequency. What is the percent of what they're going through? Is this daily? How often are they experiencing these symptoms? And then what is the severity of them? What is going on? So all of those combined equal the presenting problem. And when we look at the diagnosis, the symptoms must support it. So the client must have enough symptoms to support this diagnosis. And for some, there must be specific criteria within the list to justify the diagnosis per the DSM-5. So we need to make sure that if we do diagnosing, we need to follow correct manual guidelines for the diagnosing. Then we will get into treatment planning. So first, what is a treatment plan? So the treatment plan is a written document stating a client's presenting problems. It outlines the goals and strategies to assist the client in overcoming their mental health issues, as well as documents the progression of mental health treatment. There's multiple items that are required within the treatment plan, such as the client's name, their date of birth, gender, marital status, also their diagnosis, so the code and name. What is that F code and the name? So an example could be F33, major depressive disorder. And then that presenting problem with that level of impact, super important there. Reminder, we just talked about, we need to make sure we get that presenting problem. And then the goals. What goal does our client have? What is the objective in relation to that goal. And then the interventions, what are we actually providing? What are we able to do? What are the specific modalities of services and the treatment team? And then the progress. Has there been any progress? What is the update in the treatment plan? We want to know the biopsychosocial stressors, including those barriers to treatment, making sure we notate those so we are prepared for them. And then a plan. How can we address those barriers, or how can we continue to move forward in treatment? We need to know the modality, the frequency, and duration that we are providing services. We need to know the level of care. So again, VPBS provides outpatient level of care. And then lastly, we need the signature, licensure, and date that the treatment plan was completed. So I just want to go really quickly into the definition of a goal. So the goal is super, super important. And it is of utmost importance that we ask the client what they want out of their treatment. What are your best hopes for treatment? What will tell you when you don't need services anymore? So the goal is going to be that best case scenario. And then this could be written in a positive or negative. The goal should be passive and describe a state of being. And then the objective. So the objective comes into play as it is the plan on how or what the client will do to achieve their goal. Because of that, it is written in an active way. It is using those action verbs. And it's also written in the positive. Just remember that objectives must be measurable, achievable, and time specific. If we do not have the ability to measure the objective, how do we know when it's been met? So that is super important there. Then how often should treatment plans be reviewed? In other words, how often are we looking at the progress our client has been making towards their goal, and what should we be looking for? So progress towards goals and objectives need to be documented to show a justification for continuing to provide services. Medical necessity must be evidenced throughout treatment, not just at intake. Progress towards goal is documented as part of the treatment plan review. And treatment plans should be reviewed per our policy every 6 months for clinical services, every 12 months for psych and nursing services. What we are beginning to recommend is the treatment plan's best practice is to review every 3 months or 10 sessions for therapy or TBS. Here we can see progress review in the clinical treatment plan. So we can see the objective there. Sally will learn and implement 2 calming and coping strategies weekly to manage challenging situations related to trauma per self-staff report. And then we can see how Sally is doing with this objective in the review. So continuing the objective, some improvement made. Sally has been able to learn and implement the calming skill of square breathing and uses it on a daily basis. Sally notes a sense of calm after completing 4 rounds of square breathing each morning, allowing her to leave her room to eat breakfast in the dining room with other residents. Sally will continue working on this objective to learn other calming skills to help her manage challenging situations related to trauma. So this is a good objective review because it illustrates that she has only partially met her objective. So her objective, we want her to have 2 calming strategies, but we only have the one of square breathing. This is what is justifying the reason for continuing the objective and continuing services. Here's the medical treatment plan. So in the medical treatment plan, we want to make sure we are also being thorough in the progress review. So this person's objective there will decrease anxiety, evidenced by taking all prescribed medications daily per self-report. And then the progress. So the client has achieved taking all of her prescribed medications there. Client reports being compliant with medications, but has not been able to decrease anxiety. So hasn't managed the decreased anxiety portion of the objective. So reports being compliant with medications, but states she is still having issues managing her anxiety. This justifies the rating of some progress. So only a portion of the objective has been made. And next, we will look through our session or progress notes. What is a session note? So a session note or progress notes are notes that document or assess the contents of a conversation during an individual, group, couple, or family therapy session. They must clearly relate to the mental health objectives and goals of the client. It is a standalone document regarding medical necessity, so identifying progress with a clear link to the treatment plan. And they are a part of the clinical record. So that is super important that all of these are going as a part of the client's legal, medical, and clinical record. Next, we just have some general information that is important to go through when completing notes. So this includes needing the client name, complete sentences, correct spelling and punctuation, and no abbreviations. So I know, please refer to your supervisor if you have an approved list or any questions regarding abbreviations. However, best practice and general tips, no abbreviations is best. And then the 48-hour rule is best practice for documentation. That is actually BPBS policy as well. You need to sign your progress notes within 48 hours. And then collaborative or concurrent documentation is best practice. So making sure that your client knows what is going into their chart and actually collaborating with the client on their own documentation, on what you are able to write. And then be ethical. Make sure that you are applying ethical standards to your documentation. Your notes should be original, so there is no copy and pasting from one note to the next, even if you're providing that same intervention. No copy and pasting whatsoever. Something I promise you will be different from one session to the other. So your notes should always be original. And then just make sure that you are paying attention to that golden thread rule. So you should take things from the assessment to the ISP to the progress note. And then be accurate with times. No rounding whatsoever, exact times only. If you round or do not put the exact times of your session in your note, then you are committing a fraud, a fraudulent billing. We cannot do that. And then just consider the impact of the note being read aloud in court if subpoenaed. Just some more general tips for documenting sessions include indicating somewhere for coordination of client care if the client was not present to ensure billing does not get rejected. That is super important. Don't say that you stated and talk to the client when in reality you were talking to staff, family, guardian. That's perfectly fine. Just say that you did that. And then this language is helpful for when therapists are not billing for therapy. Billable moments include interactions with client supports, even if that client is not present for said discussion. That's totally okay, as long as, again, billable, it is over 8 minutes, and we are managing overall health and wellness. It still needs to relate to the client's diagnosis and treatment planning. Other billable moments may include phone calls, faxes, or medication sorting. So please refer to your supervisor regarding any billable moments you may be confused on. Transportation in idle time is not a billable service that BPBS provides. All progress notes should include some type of intervention working on that is related to the client's ITP. If the intervention is not in the ITP, we should not be billing for it. And then for TBS and CPST, we need to select at least one of those 10 TBS CPST interventions in the intervention section of the note. So those 10 TBS interventions come directly from the OAC, or Ohio Administrative Code. So when we select one of those 10 TBS interventions, we are following state guidelines. And then make sure that when you go through the note, we are looking for this clinical content. So we need the service provided. If you're a therapist, are you providing CBT, DBT? If you are a TBS worker, are you providing an actual TBS service or CPST? We need the treatment plan that is addressed. We need the mini mental status exam, the risk assessment or lethality assessment, We need your clinical interventions, what you provided, as well as the objective findings, your staff, your actual self-observations, as well as the subjective findings. What is the client's perspective of that treatment? We want to verify the medical necessity, as well as client progress, the plan or homework, as well as have a signature with your credentials and the date. So when we say you should be addressing the treatment plan, we mean that you should address at least one goal and objective during each session. So indicate the client's response to the goal or objective, and how do you think they are doing? Have they achieved the goal? Have they pretty much marked everything that they need to? Have they been making some or moderate improvement towards it? Or has there been no change or even deterioration or an increase in symptoms? And we can see the goal and objective are selected appropriately above. The above is a therapy or TBS example there. So we can see that the goal and objective are selected with moderate improvement happening. And then below, we have the example of nursing. So the goal and objective are put within the note. And then 5, there has been an increase in symptoms. Justification, they report an increased anxiety. And then we need to make sure we are completing a mental status exam within all of our sessions and notating what we have assessed accordingly. These are based upon clinical observation and client report. So first, there's going to be the emotions or mood and affect. So the mood, the patient can describe in their own words or rank on a 1 to 10 scale. Their mood, their internal feeling, and then their affect, that is going to be their external presentation, their facial features. So you may describe their affect as being depressed, sad, could be angry, or it could be positive, negative. It needs to be described in some way. And is this congruent with their stated mood? So if someone says they're super excited, but is frowning, their affect is not congruent with the mood that they state. And then how is their thinking? What is their orientation like? Are they actually oriented to their time, to the place, or to themselves, their person? And then that process, is their thinking logical, goal directive, or is there a flight of ideas happening, word salad? And then their perceptions, are they having any hallucinations or delusions? Then we have behavior. So in general, what is going on? Is there an increase of activity such as restlessness or agitation? Is there decreased activity? Are they withdrawing? Are they isolating? How is their eye contact? Are they avoidant or are they staring really intensely? And then their mannerisms. How's their posture? How's their fidgeting? We then want to make sure that we are also paying attention to things like their medical condition. Are there any new medical conditions that play a part in their mental health, as well as substance abuse? Any increased or changes in substance abuse? Within your note, you also want to make sure that you are addressing any extraordinary life events that could be changing the way that your client's needs are being presented. And then there is this risk assessment or the lethality assessment. So very important to note here that if you select an item within the lethality assessment, you are required to complete the safety plan. If there is a safety plan already within the chart, it is totally fine to just review that safety plan and or update it. However, it just needs to be done in some way. That is required. And if there is a risk concern, a safety plan needs to be put in place. So is there any self-harm or suicidal risks? Is there any harm to others or harm to property that may occur? Make sure to document any risks in full. And when going through the note, when going through the note process, it can be easy to break it down into steps. So step 1 includes record subjective and objective data about the client. So step 1, that's subjective data, what your client says or feels. I feel good today. I don't feel that good today. What are they saying? The general rule is to incorporate specific statements made by the client in every note. We love quotes. And then that objective data. So, what is observable by the provider during your interaction with the client on that day? We want to make sure there are notations about progress of presenting problems, review of the client homework, and a summary of the content and process of the session. Step 2. So, this is the assessment step. So, this involves analysis of what is going on in or outside of treatment that is impacting the client. The clinician should assess which interventions are effective or not. Make sure you're asking your client, did you enjoy this intervention? Did you not enjoy this intervention? What about it did you like or dislike? And then include a working hypothesis that may lead to future interventions or change in the treatment goals or objectives. Lastly, there is step 3. So describing the next steps and assigning homework. There should also be the date of the next session or explore scheduling follow-ups. And then note any topics to be explored during the next session if there are any. And do not forget that someone will always be following up on something. So I know we have talked about objective findings and subjective language. So this is what we mean by those items. Objective findings are staff observations. So how the client appears to the clinician visually, cognitively, and or behaviorally. The client appears happy, angry, etc., as evidenced by. And then subjective findings are the client's perspectives. So using direct reports and direct quotes from the client as much as possible to capture their perspective accurately. Literally saying, the client reports, I feel happy, I feel angry, etc. Here is an example of a TBS note. So Sally engaged in the beginning to create a WRAP, wellness recovery plan. Sally was able to identify several activities which usually help alleviate her symptoms of depression and anxiety: listening to music, taking a daily 15-minute walk, doing a crossword puzzle, meeting her friend for coffee in the dining hall. Sally was able to identify some things to avoid which tend to cause anxiety and bring down her mood: overeating, staying in her room all day, wearing the same clothes for several days, and watching the news. Sally identified a skill she would like to try, stating, people taking the chair yoga class always look so calm. I could probably do that and feel less anxious. Sally was able to identify what it is like when she's well, stating, I shower, do my hair and makeup, and I feel like socializing. I call my friends and family and return emails. I leave my room to attend bingo and art class. I like to play cards and other games in the activity room. I get up, eat breakfast, and go for a walk. I read my Bible, do my daily devotions and prayers. When I am depressed and anxious, I don't do those things anymore, and I am like a different person. I don't talk much. Sally reported a decrease in anxiety by the end of the session and stated, I feel a little relief from worry, knowing better what to do and what not to do. Then an example of a therapy note. First, we're going to focus on that clinician or the focus of the session. So, had today's individual psychotherapy session via telehealth. Today's session focused on processing emotions and triggers affecting the client, reviewing symptoms, processing feeling, and providing empathetic responses, unconditional positive regard, and normalization, validation of emotions and feelings for the treatment of generalized anxiety disorder and major depressive disorders and diagnoses. Clinician and client explored her current relationships, familial or other, identified her emotions, communication styles, and implementation of assertiveness, setting healthy boundaries, and saying no as necessary. The clinician and client reviewed self-report of blank, practicing and using the CBT technique, positive self-talk, or the mirror technique, taught previously in session, of creating a positive self-affirmation to use while looking at herself in the mirror to help with reducing depressive symptoms and improving self-esteem, self-worth, and self-confidence. The clinician and client reviewed self-reports of blank, practicing using relaxation, mindful grounding techniques to help reduce anger and anxiety stress symptoms. This clinician and client re-practiced relaxation by deep breathing and the mindfulness grounding technique, 5 senses, in session to assist with alleviating anger, anxiety, stress symptoms. The clinician encouraged client to continue to engage in tasks that would increase utilizing coping skills to decrease symptoms of generalized anxiety and major depressive disorders. And then here's the example of a therapy note for that client's response. So client was friendly, cooperative, and engaged throughout today's individual psychotherapy session. Client reported she has been trying to practice the CBT, positive self-talk, and saying positive self-affirmations to herself using the mirror technique as taught and practiced formally in the session. Client reported it helps at times with depression. Client reported she would continue to practice this technique, as she reported it does help when she is able to think more positively about herself and events in her life and wanting to feel less depressed. Client reported she would work more on practicing the relaxation technique, deep breathing, and mindfulness grounding technique with the 5 senses exercise, as re-practiced in session today to also help with reducing anger and anxiety stress symptoms. Client reported staying busy, distracted with hobbies and recreational activities, playing games, coloring on her phone, watching television, occasional babysitting, and spending time with family also helps with reducing anger and anxiety stress symptoms. Client reported she is doing better with assertiveness, healthy boundary setting, and saying no as necessary, and reported feeling as this has been helping her to feel better since the last session. Complimented her on the progress made. Client reported feeling equally proud of herself and would continue to practice the above. Client reported continuing to take medication and attend medical appointments to attend to physical health and reported doing okay with maintenance. Client reported feeling today's session was helpful with re-practicing relaxation and mindfulness grounding techniques to use in distress and to reduce anger and anxiety stress symptoms, aside from just hobbies and recreational activities. Client reported she would work on practicing using the above coping skills, as she reported being motivated for treatment and wanting to feel better. And we have the nursing example that we are looking for. So the narrative of the reason for the visit. So this nurse gathered collateral information about clients from client's chart. This nurse reviewed current medication orders and reconciled medication. Nurse reports compliance at this time. Recent progress notes reviewed, no new behaviors reported in progress notes. This nurse reviewed lab work. This nurse will report any abnormal findings or changes to whatever it may be. Nurse practitioner. Client reports she is having anxiety 7 out of 8 on the scale, with 10 being the worst. She reports the increased anxiety about 2 weeks now. Client reports finding her mood more irritable as well. She denies depression. Client reports she attends many activities at the facility and is the choir director. Client reports she's been in communication with family on phone and doesn't know why she is feeling more anxious. Client reports her tremors have improved. Nurse reports he is not aware of client being more anxious. Nurse cautions medication changes, as client has a history of pulse dropping low when Klonopin and pain medications were given to close together. This information was passed on to nurse practitioner. We have the example of a psych eval as well. So here is the updated psych eval. We can see that as next to today's chief complaint is marked as the same as last visit. So their blank client is a 60-year-old female currently residing in a facility or group home, their own apartment, wherever it may be. She's seen today for a follow-up psychiatric medication management visit to address symptoms related to depression and anxiety. So there we have the history. Patient is lying in bed with eyes open. She states her mood is the same. Patient reported that her depression is not great. She denies SI, suicidal ideation, HI, homicidal ideation, delusions, hallucinations, or any symptoms of mania. She states that her anxiety is, I don't know, it's there. She reports that she is eating and sleeping. She reports that she feels like she is stuck doing the same thing every day. Patient is unable to state anything that she enjoys doing. She reports medication compliance. Spoke with her about increasing her Effexor. Patient is agreeable. And then there is the plan that follows this history. So the plan is 1, increase her medication, 2, continue TBS and nursing services, and then 3, follow up in 48 weeks. And then we just want to verify that we are providing this service due to it being a medical necessity. So continuing treatment is medically necessary in order to reduce symptoms or stabilize symptoms, prevent decompensation, address symptoms, manage chronic symptoms, improve overall functioning, and prevent any higher level of care that may be needed. The best way to avoid any potential bad billing can be seen with these items. If you discover that you are billing at the same time as a coworker, a pop-up warning will alert you. Do not alert that warning. Pay attention to it. Make sure to reach out to your supervisor or double check your work so you know that you have all the correct times listed. If you do, make sure to reach out. And then ensure to bill for those exact times. Do not do any rounding. Again, that is fraud. So providers who are consistently billing exact times are more likely to be flagged for fraud by insurance companies. So if you continually bill for 9 to 9:30, 9:31 to 10:01, have exact timing like that, or you have the same exact timing from one day to the next, it is way more likely to be flagged. And then we want to document who, what, or where accurately. And careless mistakes such as incorrect place, where the service took place, such as that, is also careless and can be considered fraudulent. Make sure that you're paying attention and are able to do things accordingly. And just be sure to double check your calendar appointments to avoid these minor errors. If you notice that there have been any errors occurred and you can no longer edit your note, make sure to reach out to your supervisor for assistance. And then what is needed for that collateral contact? So we love coordination, and it can be critical to progress that we coordinate with others involved in the client care. When we do a collateral contact note, we need the following information. The type of contact, is it in person or over the phone? The reason for consult, the agency or relationship to the client, the clinical justification for that consult, any follow-up needed or recommendation, and then why the consult was medically necessary. So we always want to make sure that we are relating it back to the treatment plan and indicate follow-up steps requiring any further treatment. Generally, this could be a CPST or a phone call, but it still has to relate back to the treatment plan and may not be a CPST intervention. And here we have an example of a TBS collateral note. So we can see in the interventions that coordinating has been selected, coordinating with the natural supports and someone who is outside of BPBS. And then in the client or support team's response, there's collateral interaction with someone outside of BPBS, and there has been identified symptoms. And then in the detailed response, the mother contacted Ryder to discuss Ben's increase in depressive symptoms and having a hard time dealing with the passing of his father a year ago. He is called off work, not shower, and sitting in his room majority of the day and sleeping more. Mother wanted ideas to help my son through this time to be able to deal with his grief, but also being able to function in society and keep his job. Discussed moving up his session and scheduling a psych appointment with the nurse practitioner to see if there are any assistance that can be given there. Discussed having access to a safety plan and talked about coping skills of deep breathing and about positive statement exercise reviewed in last session. Mom agreed she will remind him to practice those coping skills and try to have Ben use his hygiene chart. And then there is the plan, that follow-up. So the items that will be requested or will be done outside of the session. So requested for mom to remind Ben to utilize his coping skills from session and utilize the hygiene chart to try and shower at least once this next week, allowing him to pick the day. This writer will contact the nurse practitioner and nurse reporting increased depressive symptoms and coordinate a sooner follow-up appointment. Writer will also see client in 2 days to check in and continue to develop more coping skills and decrease depressive symptoms. And here we have an example of a nurse collateral note. So we can see that there are the common reasons for the visit, training and education without the client has been selected, as well as that collaboration with other professionals. Notice care coordination, yes, has been selected, but managing medication with clients has not. So in the care coordination, there is that narrative for the reason. This nurse met with VDES management, blank and blank, along with supervisor blank, RN via Teams. This nurse collaborated and educated management regarding nursing delegation requirements, appropriate documentation, progress towards goal and medical necessity, and symptoms of diabetic ketoacidosis. This nurse explained that documentation and proper records are needed of blank's blood sugars, so this nurse can collaborate with his endocrinologist to update physician orders. This nurse emphasized that this nurse must be contacted for blood sugars outside of normal, and if directions are given, they need to be followed to ensure client safety. Discussed ways to improve communication between nursing and management. This nurse visit is medically necessary to ensure proper nursing delegation and medication administration per DODD rules and regulations. For our NPs who may be collaborating, we have the narrative example here as well for that CPST note. So the NP, or nurse practitioner, spoke with Betty's staff, Sue. NP and Sue discussed Betty's current and recent mood and behaviors. Sue reported that Betty has done very well since previous appointment without repeat of violent or aggressive behaviors. NP and Sue discussed previous medication changes as well as utilization of PRN anxiety medication when applicable. NP discussed importance of continuing to monitor mood and behaviors for need for further adjustments. And just remember, we need to tie everything together using that golden thread. So when we have the golden thread, we have medical necessity. We are looking for the problem. It reflects the diagnosis, describing symptoms using behavioral language, goals, the ideal solution, objectives, what the client will do to achieve the goal, interventions, what the staff does, what you're actually implementing, the progress reflects the problems and goals, the barriers, if they're biopsychosocial stressors, and any assessments of risk. And we want to make sure that within our session notes, we have the client perspective. So first and foremost, we always want that quote. So any kind of quotes, making sure that we are being very accurate with what the client is wanting or stating. And then staff observations, how the client appears physically and or emotionally, any interventions, what the clinician is actually doing within the session. The assessment explains how the client appears, what client says, and justifies the intervention. We have the risk, if there's any violence to self or others, any progress between the session or happening during the session, as well as that planner homework, what the client will do between sessions. And remember that the better the homework, the more likely there will be progress in treatment. Just a quick reminder on interactive complexity. Interactive complexity is for our therapists and nurse practitioners only. It can be added to psyche val codes 90791, 90792, psychotherapy codes 9832, 9834, or 9837, group psychotherapy 9853, psychotherapy add-ons for EM services, which is the 9833, 9836, or 9838. Please refer to your supervisor for any coding questions or concerns regarding interactive complexity. Interactive complexity refers to a specific communication factor that complicates the delivery of a psychiatric procedure and occurs during the delivery of the service. Common factors include more difficult communication with discordant or emotional family members and engagement of young and verbally underdevelopment or impaired patients. Interactive complexity may be present for the following individuals. So they have other individuals legally responsible for their care, they're minors or have a guardianship, those who have requested others be involved in their care, adults accompanied by one or more participating family members or interpreters and translators, those who require the involvement of other third parties, so child welfare agencies, parole or probation officers, or schools, and nonverbal clients. They rely on communication boards and other cues to communicate during sessions, other communication devices. If you find that your client is going into a crisis, a therapist or nurse practitioner has to initiate the crisis services and codes prior to any nurses or TDS. A crisis code is used for an urgent assessment and history of crisis state or risk assessment, a mental health status exam, and safety planning. This includes psychotherapy, mobilization of resources to diffuse crisis and restore safety, and implementation of psychotherapeutic intervention to minimize the potential for psychological trauma. This is typically life-threatening, complex, and requires immediate attention to a patient in high distress. The time counted towards the service must be face-to-face with the patient and or family. The time does not need to be continuous. The full attention of the provider, the physician, or other qualified healthcare provider must be devoted to this patient or family. The client must be present for some or all of this service. Reference the crisis and safety planning video for additional information and details for content of billing crisis. We definitely need to make sure that we are also documenting all information. This includes any documentation that may be non-billable. Remember, any service that is under 8 minutes is a non-billable service. However, that still needs to be documented. Non-billable documentation is important as it supports the need for discharge if clients are not engaging in treatment. It supports clients who are engaged but struggling with other barriers to treatment, and has legal aspect. Remember, this is all a legal documentation that we are putting in the client's chart. And then the discharge. So the discharge summary should be review of the treatment plan and include all of this information: the discharge date, the reason for discharge, any kind of SNAP information. Remember, our SNAP is the client's strengths, needs, abilities, and preferences, the client's response to their treatment, the condition at discharge, any follow-up recommendation, how the client was informed of the discharge. Were they told via phone, a letter, or within that session? And just as a reminder, a discharge letter is not sent to clients who have passed away or who are within contracted facilities. So now that we have been through the training, you should be able to use the clinical documentation process for successful note writing and treatment planning. Demonstrate how to translate your work into behavioral language used by insurance companies, and apply the golden thread to justify medical necessity. All practicing behavioral health providers must have a working knowledge of medical necessity to meet regulatory standards of practice. If you are struggling on medical necessity, do not hesitate to reach out to the appropriate sources or go back and review this video again for additional guidance. And just make sure to continue to work through medical necessity in your notes. Otherwise, if you have additional questions, please touch base with your team lead or supervisor for additional guidance. That is all I have for you, so thank you and have a great day.